Get started. Thanks again today for joining us in our webinar on HIV and health-related needs, leveraging community interventions to support patients with HIV. This webinar is brought to you by the National Center for Health and Public Housing. And before we continue, these are just a few reminders for everyone that all participants are muted upon entry. Please make sure that you engage in the chat if you have any questions or if you have any strategies or promising practices that you would like to share with us today. Please also raise your hand if you'd like your line to be unmuted. Today's webinar is meant to be an engaging session, so we will be asking some questions to our audience today, and we really encourage everybody to participate. This meeting is also being recorded. The slides and the recording link will be sent to you all via email after today's date. And as always, we also like to learn more about you. So please let us know in the chat, what is your name, your title, the name of your organization, and what state you're also joining us from. So the mission of the National Center for Health and Public Housing is to strengthen the capacity of federally funded public housing primary care health centers and other health center grantees by providing training and technical assistance. The content of this webinar is 100% financed by the Health Resources and Services Administration and do not necessarily represent the official views of HRSA, HHS, or the U.S. government. So with us today, my name is Fide Pineda Sandoval, and I am the TTA manager at NCHPH. And with me, I also have my colleague, Ola Jumoke Oladipo. You can also call her Jumoke. She is our health communications and research analyst. She will be helping us today with moderating as well and some of the logistics throughout our webinar session. And in the line, we also have Dr. Kevin Lombardi. He is the Director of Research Policy and Health Promotion at the National Center for Health and Public Housing. And he will be the one providing the expertise on the HIV and health-related needs in health center communities. So Dr. Lombardi serves as the Director of Research Policy and Health Promotion at NCHPH, and he's also the Vice President for Research and Evaluation at North American Management. In his expertise, he also integrates clinical medicine, public health, and systems evaluation to enhance primary care quality, workforce development, and policy alignment across the U.S. safety net. And he also directs national assessments and program evaluations and has published in major journals throughout his career. Dr. Lombardi also holds an MD, an MPH from George Washington University, combining medical training and expertise in public health analysis, policy, and data-driven evaluations.
Hi, everyone. I think my job changes a little bit every time Fide reads that. I don't know if you just gave me a promotion or not, but another couple words in there. Hi, everyone. Nice to meet you. I'm seeing some things pop up here. Des Moines, Iowa. We've got Texas. We've got all sorts of weather on the line today. Let's bring our moods together. Um, uh, what else? We get Arizona, um, County Public Health. We get a medical center, Methodist Medical Center. Let's hear some more about what you guys do for your organizations. Case manager. Okay, cool. Great. So I think we're right on target today. Um, uh, so let's get right into it. This is HIV and health-related needs, leveraging community interventions to support patients with HIV. And really the core of everything today is going to be those non-medical supports and making sure that individuals with HIV are getting the support that they need. Um, for those of us who work with the HIV positive individuals on a regular basis, and especially in the new diagnosis phase, when the infection is newly identified and there's a lot of conversations, difficult conversations, and a lot of learning. It's that a diagnosis of HIV changes your life significantly. And it's not like it's something people schedule. It's often a surprise, an earth-shattering surprise for them. And there's a lot of patient education that needs to go into breaking down what their preconceived notions about being an HIV positive individual might be, to bringing it more to what medical reality is. That's a series of conversations, of course, but making sure that they have the support that they need in that period of intense transition. And it's really what it is on the core psychological, in a core psychological sense. For many individuals who are diagnosed, it changes a lot of their life and it scares the heck out of them. And that is incredibly destabilizing to most people's lives. If we take these diagnosis events as opportunities to step in, we provide individuals with continuity from during this transition of their life. Now, when I trained. My mentors were of the generation that was there when HIV was a relatively new condition. And oh boy, have I heard horror stories about end stage AIDS and when there really were and no antiretrovirals available, there were really no strategies available to help people. Um, those pictures are what is in folks' minds when they find out they have a diagnosis of HIV. Today, thanks to medical therapy, thanks to advanced pharmaceuticals, HIV is managed in a way that's very similar to other chronic diseases and is often described as a chronic disease state now. So folks can live very happy, very long lives, but those periods of transition are opportunities to provide bridging uh, as folks adapt to this reality. Next slide, please. Today, we're going to talk about how health-related needs influence engagement in HIV care and treatment outcomes, describe community intervention models that support patients with HIV, and we're going to focus a lot on community health workers and how they can address health-related needs amongst those living with HIV. Next slide, please. We're going to start with a case study, and I see we've got some more. Okay, cool. We've got Connecticut on the line too, a CHW. Um, if you haven't put your stuff in, please do it so we can see sort of the mix of backgrounds of our diverse audience. We are going to go right into a case study. What I'm going to do is I'm going to read the case study. There are questions throughout where I will stop you, but I want to think us to think as deeply as possible about the confluence of different dynamics in this patient's life. We will talk about chronic disease. We will talk about HIV. We will talk about social challenges, and we'll talk about all these things in a single narrative, and it allows us to see how they work together in context and create difficulties for patients and how we can support them, of course. Mr. Stevens is a 45-year-old man with a past medical history of COPD, asthma, and type 2 diabetes. The patient has been living with HIV since 2007 and has maintained suppression since 2019. The most recent HIV viral load test indicated less than 200 copies per milliliter. Okay. He presents at the clinic today to catch up on his annual exams and due to sores that have recently appeared on his cheeks and the roof of his mouth. Okay, next slide, please. Prior to seeing the patient, you perform a review of his EHR record. It indicates the following. The patient received his HIV care, including his antiretroviral prescription from Dr. Simon, an ID physician who retired in 2024. Pharmacy claims data are not available in the EHR, but records note that Mr. Stevens was previously prescribed and taken Travaki Descovy during the last note of 2024. Okay, so he was on therapy. We do know he was seeing an ID physician. Next slide, please. Looking at Mr. Stevens' primary care records, the following information is also reviewed. He was last seen at the office in April 2024. His last hemoglobin A1C is noted to be 9.3 in April 2024, and he's been seen at this health center since 2012. There's one additional episode where he was lost to care, and that was from 2014 to 2016. And per the social worker, he was noted to be unemployed during that period. Okay, next slide. First question. We just went over a lot about Mr. Stevens, but I am curious to know what your initial assessment of his medical records. And take a minute, put some things in the chat. What are your thoughts? Fide, could you go back to the sort of the action slides, and so folks can see?
Yeah.
And Fide and Jimoke, if I don't get hands, I'll ask you to have some questions ready too, because I know this is your first time seeing this case. Okay, let's head to the question again. What is your initial assessment of the information in Mr. Stevens' medical records? What is this man telling us through his history? Fide, Jimoke, do you have any thoughts?
One of the things that stands out to me is that he waited such a long period of time to get his annual exam.
Mm-hmm.
So I think it kind of makes me question like what was happening throughout that time, what were some of the challenges that he was experiencing for him to not follow up with his exams.
Yeah, so we have a long period of not seeing the patient. And if you go to the next slide, we can look into those details too.
Yeah.
Looks like, oh, next one after that. Yeah, so we had one additional period where he was lost to care. And we haven't seen him in the office since April 2024. That's a relatively long period. Now, thinking about the rest of the story, what else happened during that period that is sort of the key connector here? There we go. They stole it from you, Fide.
Yeah.
You gotta watch out for that audience sniping in. There was a key piece of information there. And I'll tell you, this story happens all the time, especially if you're practicing and if your health center is in a rural area and your ID physician, there's just one guy in town that does it, if you're lucky. And it might be someone who needs to come in and telehealth once a month. So, ID physicians retire. Like this exact situation will stare you in the face at one point when that transition happens in your area. Go back to there's a part that talks about Mr. Stevens's physician. Yeah, here we go. Dr. Simon. He retired in 2024. When also do we stop seeing our patient? We stopped seeing him in a primary care sense at the same time. So there was a ball that was dropped here, and that this patient's ID physician retired. He became lost to care after that, and there's a number of reasons why. Perhaps the Dr. Simon's office managed his medication and were the ones that got him on medication, and perhaps they provided him a very important structure for continuing with his care. Perhaps the physician retired abruptly or left town abruptly. Perhaps the physician passed. These transitions affect patients in very real ways, and sometimes it can lead to being lost to care. It's a very common story. So around 2024, he loses his ID physician, from what we can read, and he stops being seen at our facility as well. So genuinely lost to care. What has happened to him since 2024? We don't know at all. We don't know if he's been taking his HIV meds. We don't know if he has a different ID physician somewhere else. We don't know what happened at all. We don't know if he's been getting primary care elsewhere. So this patient, the red flags just come right off of them in all directions. And that there are a number of major issues that could be life-threatening for them. And from a clinical perspective, we're gonna have to dot some I's and cross some T's to see, have you continued care somewhere else? Who else? Who is doing managing your HIV care now? And a lot of times that question will be, well, doctor, so and so was, but no one's been doing it since then. Well, have you been taking your antiretrovirals? Well, no. Like, people don't just scream, I'm medication non-compliant. It's much more complicated to them in their real lives. So there will be a lot of piecing together of narrative to figure out where this patient was lost to care and where intervention needs to pick up. But this is a very common story. Other things. Oh, let's see. Look at the chat here. Um, uh, is his care up to date? Yeah, I guess I stole it back. I'm sorry about that. But 100%, 100%. Um, yeah, it seems like this patient fell off when his provider stopped practicing. Very common story. Does anyone on the line practice at a health center and organization that's in a rural area or a place that struggles with obtaining ID physicians or specialists? Does anyone have some thoughts about that? Anyway, so moving on. Let's head back to the question. Yeah, just speak if you want to say something, by the way, folks. This is an open forum. Other things, let's stop here for a second. What else on this page is popping up that is of specific importance for an HIV patient? And in sort of the sort of chronic care spectrum too. What other aspect of this patient's health history is important for us to address? Any numbers on there that scream out?
His
9.3.
yeah, I was just gonna
9.3 is
say
the
that.
number. And that's his last A1C. This patient has been left to care since April, lost to care since, from what we know, April 2024. Now, this is a question for everyone. What does 91 point, what does hemoglobin A1C of 9.3 tell you about how this patient is managing his diabetes, if they have it? Do they have diabetes? And are they managing it well? We got some poorly managed, we got some not well managed. Um, and yeah, okay. Well, I don't know. Say I don't know anything about A1C. It's a number, you see a lot. But Sarah, can you tell me why this is poorly managed? And if you can add why you think it's also important for a patient with HIV, you get bonus points.
Muted. Can anyone hear me?
Yes,
Yep.
ma'am.
Oh, sweet. Okay, cool. So 9.3 is indicating a much higher than we would prefer number for any person who is diabetic, which this person would be considered to be so, though
Hmm.
I don't know if we have a diagnosis. Um, but just in terms of the poor health outcomes that could be associated with poorly managed diabetes, Those are kind of just incrementally so in someone who has other chronic health conditions like CHIV.
100% nailed it. Renal disease in particular is an issue with patients with HIV. And one of the outcomes of having persistently high blood sugar is your A1C goes up. And that is a very good metric of what your vascular health is now and what it's going to be. Sugar in the blood leads to a speeding up of every chronic process that goes on in the capillary, from the capillary level to the bigger vessels. So when someone has a A1C of 9.3, they're going to have microvascular damage throughout their body, and that really is an issue with the kidney, in particular with HIV. Um, we really need to watch diabetes very, very carefully in patients with HIV. So when I see a hemoglobin A1C of 9.3, that really scares me. Now, they're diagnosed at between 6.3 and 6.4, and the A1C is logarithmic. So every zero point 0.1 it goes up, it's not proportional, it's referring to a even greater concentration of those glycosylations on the A1C. Now, A1C tells us a lot about time too. Now, what it specifically measures is something called glycosylation on the blood vessel. And the life cycle of a red blood cell is about 4 months. So when you see an A1C of 9.3, it's measuring glycosylations on those blood cells. So it has a life cycle of about 4 months. It's telling you this is the average exposure to sugar in this person's blood over the past 4 months. So 9.3 says it's persistent and it's high, which means this individual's diabetes is very poorly managed. They are let's say, a low-hanging fruit for intervention, may not be taking any medication at all, and their diet is likely very, very high in sugar and processed foods. So this is a huge area for intervention. It also tells you a lot about a patient's life as well. Um, okay, let's go back to the question and keep going. Okay, I think we took care of this one. Are there any differences between Mr. Stevens' previous and current loss to follow-up? We talked about this a little bit. Is the in the past the patient had been lost to follow-up after a loss of a job, likely a loss of insurance. In this circumstance, his physician retired. Next slide, please. Okay, so this patient, when he comes to your FQHC or your health center, goes through a social needs questionnaire. So it gives us some information about the things that they are going through and the types of non-medical supports they need. This is the Well RX questionnaire. There's a link in the bottom to it if you're looking for a good screening tool that is adaptive to local needs. The Well RX questionnaire is a great asset. But let's look what this patient has going on here. Looks like in the past 2 months, they did eat smaller meals or skip meals. They are not worried they would be homeless in the future. They are having trouble paying our utilities, having trouble finding a ride. That might explain some of the loss to care as well. And next slide. The patient is unemployed or without regular income, does need help finding a job. Okay, so we got a good snapshot of sort of the social complexities here of this patient's life. Clearly under financial strain. The patient is also without a job, and is likely going through a life transition at the moment. Next slide, please. So stress is the key terminology here. So what additional questions would you ask Mr. Stevens after reviewing this questionnaire and seeing these things? You've got this guy in the office. He's got chronic medical conditions. He's got HIV. Wasn't being seen. You get this questionnaire that shows all of these social issues that they're going through. Any additional questions for him at this point? Our CHWs, what do you think? And we're thinking social support. What are the assets that are going to allow this patient to live their life in a healthier way? Someone's mentioned mental health. Shanice Hutton, are you able to tell us why mental health came to mind for you? Why would we care about mental health? Nothing came up about it. Why is it on your mind? Shanice, you're muted if you're trying to speak to us.
Might be something to look into, but everyone doesn't want mental health services.
Hmm. Well, for this individual, is there something about their history that made you think that mental health services may be appropriate or screening for mental health issues?
Aside from his diagnosis of HIV,
No, I
or
mean
any
that could be
side,
that can be the answer. Yeah.
or like maybe like if he's connected to like any support groups also.
Yes, 100%. So individuals with HIV, and this is an assumption in your answer, which I appreciate, have a very high likelihood that they will also require behavioral health services at one time in the near future. In particular, with folks that are newly diagnosed, support groups and so forth have been shown to be incredibly effective with helping people to transition and supporting their mental health long term in these periods.
I am so sorry this
Um,
is so loud. It's okay.
so making sure that those are identified is very important. Mental and behavioral health services. Anything else come to mind?
We have a participant from Teresa Floyd. She said support services such as Ryan White, case management, employment, and housing assistance.
Ms. Floyd, are you able to tell us what your thoughts or why those services came to mind?
Are you able to hear me?
Yes,
Yes.
ma'am.
Hello. Um, so I'm just looking at some of the things he's struggling with, including food insecurity, employment, housing. I'm also wondering about does he have health insurance? And so being that if he's unemployed, he may be eligible for Ryan White services that might offer a case management that can help sort out and prioritize some of the things he needs help with. Um, so that's all I was thinking was that this can be overwhelming and he has several areas and maybe a case manager to help prioritize and connect him to things like maybe food stamps, um, employment resources, things to help with housing and utilities. I was just thinking that
Mhm.
might be helpful.
100%. You nailed it. Very comprehensive. This patient is going through a severe life transition. There are a number of different yeses on this questionnaire that are red flags for his general stability in life. And being sure we can find out and tailor those programs specifically to those existing patient needs is one of the best ways of making sure that this patient is happy, healthy, and well managed going forward. Next slide, please. And I think we'll keep going. Next slide. So you perform a comprehensive physical examination and a focus interview with the patient. When asked about the results of his non-medical needs questionnaire, the patient notes the following. He's been unemployed for 2 years. For employment, he performs odd jobs and drives Uber, but is consistently late on his bills. He's a resident of public housing. He notes poor compliance with his ARV therapy and missed appointments with providers due to, quote, stress, loss of insurance, and difficulty finding a new ID provider. When asked if he knew if he was eligible for Medicaid, the patient notes that he hadn't thought about it. The patient is unaware of other safety net resources that may be available to him. Next slide, please. So we do the clinical exam, and let's look at his results. Today, 110/80, heart rate 62, weight 135, pale blotchy skin. In 2024, 140/90, heart rate 74, weight 175. Okay, what are we noticing in the difference between these two values? Two sets of values. Any thoughts? Is there a particular metric? Yeah, you nailed it, Sarah. The weight loss, that's pretty significant. Um, so that's about 25-30%. And I see that, and I see pale, blotchy skin in the context of a patient who has been lost to therapy with HIV. This is a scary situation. Uh, Next slide, please. Okay. So you open the patient's mouth, and this is what you see. And this is opportunistic oral candidiasis infection. Candida is a fungi that is typically very well suppressed by our immune systems. When folks have HIV that transitions to AIDS, they have very few helper T cells left, and their immune system is unable to keep out those sort of daily threats that are typically so well controlled. So you start to get stuff like this. And most of the AIDS defining illnesses are all different conditions that are typically kept in check by healthy immune system. So here's what you see: oral candidiasis. Next slide, please. And here's another picture of sort of what, and the rest of these are sort of examples of additional AIDS-defining illnesses. But here's another look at what oral candidiasis can look like. You can see sort of the white rings towards the back of the patient's throat. Next slide, please. So you open up the patient's mouth. That's what you see. What is the number one priority for his care, and what steps should be taken next? Thoughts? Dental care, schedule follow-up. You're getting there. These are all important things. These are all very important things. Um, Yeah, there we go. The viral suppression and the diabetes management. And remember, this patient has a very low was previously had a very low viral load, was well controlled, then was lost to care. As a result, we have a loss of weight, and we have oral candidiasis. This is a patient that has AIDS. That is and we still don't know when was the last time he took antiretrovirals. So at this point, the priority is connecting the patient to ID care. So and this is where it can get challenging too, depending on what part of the country you're in. ID doctors are hard to get appointments with, and they may not be available. But this is an all hands on deck situation where the patient must be linked to a provider who's comfortable providing his HIV care. So that is the number one priority here. Another main priority is his diabetes as well. The patient is has an A1C of 9.3, is already sick, and his diabetes care needs to be prioritized 100%. Next slide, please. What additional resources would be appropriate for Mr. Stevens at this time? So we went over programs a little bit. I won't nail this too hard. But patient has a need for a variety of different supports, which I think one of our colleagues uh, mentioned earlier. But just to go over them again, like the patient has the opportunity for employment support, travel as well to the health center may have been an issue related to the appointment missings, and ensuring that the patient has insurance, food support as well. These are all supports that should be prioritized for this patient at this time. Next slide, please. Some additional aids of defining illnesses, but here's another picture of oral candidiasis. Next slide. Additional different AIDS defining illnesses. This is a secondary oral pseudomembranosus, candidiasis infection of gums. Next slide, please. And again, this is a pretty severe infection of the mouth. Next slide. Okay, so let's go into promising practices now that we've done our case study. There are no other candidiasis pictures, FYI. Um, some publications that are worth circulating between you and your colleagues. I put in here integrating community health workers into HIV care teams, impact on HIV care outcomes. So this study looked at 10 different demonstration sites, including health centers and Ryan White clinics across the country between 2016 and 2019, and followed 600 people with HIV engaged through CHW programs. Next slide, please. What they studied was the impact of CHWs on individuals with HIV related to key metrics. And some of the comparisons are very telling about show us just how important CHWs are for individuals with HIV and how supportive their services can be in real ways that affect patient life and quality of life. Primary care visit in the past 6 months was a metric that I thought was pretty startling. From the baseline, patients who were not seeing a CHW, 50% had a primary care visit in the past 6 months. For those who were seeing a CHW, that went up to 84.7%. That's huge. That's a big change. Antiviral therapy prescription. The baseline was 66.9. After 6 months, that's 91.3%. That's a huge change. And the viral suppression of less than 200 copies per milliliter. The baseline was 22.4, and after 6 months, 43.7. So these are huge magnitude changes, and the difference is having the CHW involved. And with an understanding of what CHWs do, they're not just connecting folks to resources, they're providing support and connecting to support. The change isn't surprising, but it's important to evaluate this within the context of value-based care. Patients who are seeing their primary care provider, getting their antiviral therapy, and have viral suppression of less than 200 are in a sort of off the cuff, from a off the cuff perspective, they are much less expensive to treat. That is the sort of core concept broken into value-based care that shows us that these interventions are worth an investment. if your HIV patients are seeing primary care more, getting their therapy, and they have viral suppression, that patient is going to be healthier, and that cost of care has effects on your health center. Putting through interventions like this are a good way of, I like saying, supporting both the financial health and the of the institution and the population health as well. They help both at the same time. Next slide, please. Sort of looking at giving you a visual look here to see you can see the magnitude of just what a difference a CHW makes on HIV care outcomes. Next slide, please. So let's talk about integrating CHWs into HIV care, and sort of some of the barriers to integration that are heavily mentioned by our health center colleagues and also prominent in the literature. Number one is a big one, and that's unclear CHW roles and responsibilities within care teams. Essentially, in those sorts of dynamics where the CHW does not have an established role within a care team and a set areas of responsibility within care management, they can often get sort of pushed to the wayside and be less involved in the care. When you are designing interventions with CHWs, it's important to make sure that these individuals have very core areas that they're focusing on, and very clear communication channels with other providers, physicians, nurse, advanced providers, and so forth, so that the rubber is actually hitting the road. Um, Number two, a need for ongoing coaching, supervision, and peer support among CHWs. I'll say that the CHW training is very general, and folks throughout their careers end up working with very specific patient populations and sort of learning on the job to a certain extent. But providing more individual coaching and supervision to CHWs allows them to understand the patient population better. And if they know the patient population better, they can network them to care more effectively. um, uh, Lack of standardized training for CHWs, and lack of information about navigating aging and HIV. The average age of those who are diagnosed with HIV is going up every year. And when we have an individual that is of advanced age and has a new HIV diagnosis, and of course, in many cases, many different chronic care diagnoses as well. The balance of care is very difficult compared to younger individuals, and requires many more resources as well. And of course, weakened or fragmented referral systems. This is why Mr. Stevens was lost to care. He lost his ID physician and he didn't get anyone to fill in the gap. Next slide, please. Some resources for folks who are looking to integrate CHWs more deeply into their HIV care. And this guide is absolutely fabulous, a guide to implementing community health worker program in the context of HIV care. It is from nuts to bolts, how to set up a HIV care CHW program. And it goes down to the level of detail of specific forms for specific parts of the CHW HIV CHW patient relationship in this context. It is extremely detailed and a great read if you're looking to make your program more efficient, to start a new program, or add new layers of compliance to that. The link is in the bottom left there. Next slide, please. Let's discuss the relationship overlap a little bit of CHW and HIV continuity of care. CHWs link individuals in much more durable ways than other parts of the care system. CHWs, when they follow a coaching style system, the relationship drives compliance in a very real way. In the context of value-based care, this has very real effects on patient health metrics, and it has very real financial effects on health centers as well. Community health workers are a great way to improve both the health of your institution and the health of your patients as well. Next slide, please. So priority patients for CHW HIV interventions. And this is with an understanding that CHW time is a limited resource. Even for health centers that have those programs staffed, the time is not the time is limited. So it often helps to triage patients and identify high priority patients for these programs when space is limited. According to the literature, these are sort of the main areas of patients that should be identified for priority intervention. So number one, patients who are not virally suppressed. These are patients that are high risk of AIDS development and are appropriate intervention targets. New onset HIV diagnosis. For these individuals, the need for social support is linked to the difficult and often chaotic transition to HIV positive status. Unsuitable housing or unhoused individuals. If you don't have a house, it's easier to get lost to care. And housing is, in a variety of different ways, supports patients and their continuity, including their continuity of care. Patients with a history of missing or late appointments. Those with mental health disorders, the recently incarcerated, and patients with SUD. These are all the priority patients for ACHW interventions. Next slide, please. And some details on locating priority patients. How do you find them? And programs are only as good as their referral strategies is sort of an important thing to remember here. A good way to start is take a look at your program data. Search program rosters of past HIV linked to care programs at your institutions or partner institutions to identify priority patients or potential users of your programs. Surveillance data. Looking at your EHR and looking at your local Department of Health data to see to ask for or obtain lists of clients who have had a viral load test in the past 6 months. This is a good way to identify folks that are in need of intervention and perhaps got a new test recently that indicates they are at high risk. And review testing data. Your clinical testing data is a gold mine for referrals, and health centers can utilize that to identify eligible people and link them to their programs. A sort of recommended strategy is review a list at weekly team meetings and contact individuals from there. Next slide, please. And a little bit about how CHWs can enhance HIV care teams. CHWs function as a sort of an adhesive within a care team. It helps to support those existing connections and add an additional layer of social support as well. So one, assisting people with HIV to become aware of their status and education about their status. The perception about what HIV is versus the reality of what it can be, or the reality of what living with HIV is often a difficult barrier to traverse. When patients think about HIV, they think about those pictures I showed you earlier. They think about AIDS, they think about those horror stories. CHWs are important parts of the patient education spectrum, and providing them with standardized training to educate people about HIV and about what life with HIV looks like is an effective strategy. Linking and engaging people with HIV to their medical care. Many do not have insurance, many are not connected to providers, and will need help with referrals to advanced providers as well. When that doesn't happen, they are often lost to care. Helping people with HIV to adhere for treatment, depending on the complexity of the non-medical complexity of the patient's life, this can be more difficult than it seems. If the patient's unhoused and they don't have an address, how do we make sure that they're getting their HIV medications? If the patient is unable to drive to go to an advanced provider, drive to go to their ID physician, how are we going to make sure they get on their medications? CHWs, checking in with these patients and helping them fix things along the way is an effective way to make sure that that continuity happens and doesn't just stop at when it hits a barrier or it hits a complexity. And of course, explaining the health benefits of other types of available assistance with people with HIV. As programs often need to be sold to patients, even when they are a service and when they don't have an additional cost. Especially if the patient needs to put time or has difficult getting transport to these activities, they often need to be sold to the patient. And CHWs know more about the programs in many cases, and they can articulate the importance of ancillary programs to patients in a way that is in their language and makes sense to them. And when we're looking at patients with, especially with new diagnosis HIV, loss to care is our main concern. So being able to keep that transition as smooth as possible increases the likelihood the patient gets on ARV therapy, the patient is seen regularly by his providers and is not lost to care. Next slide, please. And I have here some suggested CHWs, tasks and activities for working with patients with HIV. And it was one, and this is designed for those priority patients that we went over in the preceding slides. So one, weekly client check-ins to measure progress that include medication compliance check, appointment reminders, and compliance checks, and following up on additional referrals as needed. It's probably the most high yield use of time within the context of HIV care. We need to make sure these patients are taking medication. We need to make sure they're going to their appointments. Two, conducting regular education sessions with patients, and some suggested subjects are HIV transmission, patient safety, ARV medication basics, chronic disease and HIV connections, and wellness and lifestyle. A diagnosis with HIV cannot be solved, the information gap cannot be filled with just a couple of education sessions. This is a longitudinal relationship, and CHWs are able to provide that education in a structured way. My recommendation is to pick a topic every week. Go over HIV transmission, spend as much time as you need. Go to the next one, the next topic the next week. Over time, patients are able to accumulate knowledge, and they're able to come back with more information and understand their condition better. And of course, documentation. Make sure to document each encounter on a separate note on the EHR. This ensures better collaboration. Folks do read these, and they do provide very important data points from a population health perspective. So ensuring that documentation is visible in the EHR is one of the best process improvement focuses you can have if it's not already done. Next slide, please. So we've got a few minutes for questions. And so I'll say, speak up if you have any questions or additional topics, ideas or promising practices from your health center, what you folks are doing to support individuals with HIV.
Mhm. All right. So while our participants think about any questions or anything else you would like to share with us, maybe some strategies that you're also currently implementing in your health center. Okay. Just a reminder to please complete our post-evaluation survey. Please let us know how we did. We always take into consideration your feedback. And also let us know if there are any other future topics that you would like to see in our upcoming sessions. But yeah, let us know if you have any questions right now.
Well, if we don't have any feedback, we can go ahead and wrap things up.
Yeah. All right. So thank you everybody for joining us today. If you have any other follow-up questions that maybe they just come up after the webinar, here is our contact information. You may contact us here. And again, the slides are going to be provided to you after today's session. So thank you all and have a good rest of your day.